Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of the Positive Aging Community. We're excited that you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. We're able to bring these discussions to you along with copies of the Positive Aging Sourcebook, thanks to the support of our Positive Aging Community Champions. Visit proaging.com to connect with them and find hundreds of other resources. Today we have a recording of an in-person event that was hosted in Fairfax, Virginia, in partnership with the Fairfax Village in the City, the Association for Frontotemporal Degeneration, ProMedica Arden Courts, the Northern Virginia Senior Resource Network, and Positive Aging Community. We are going to hear a presentation by Will Reiter, who's the Education Program Manager for AFTD, and Jen Morabito, who is an ambassador and has gone through a real-life experience of having FTD in her family. You're going to hear about how challenging this disease is and learn how it differs from other dementias as far as symptoms, support, and care. So let's jump into the discussion.
We educate all groups of people about FTD because unfortunately not a lot of people know that much about it. Although we must say that in February, when Bruce Willis's family announced internationally that he was diagnosed with FTD, it really brought about a groundswell of interest, questions. We had a lot of calls, people that work in the field as well as people who recognize those symptoms and are wondering how they can get a diagnosis. So we are going to try to give you some new information about FTD, and we'll go to the next slide. So one of the things that we want to do today is really paint a clear picture of how FTD differs from other types of dementia. I actually worked for the Alzheimer's Association for about 12 years, and I certainly knew of FTD. I sometimes talked a little about FTD, but I found since now 2.5 years working at the Association for Frontotemporal Degeneration, it's a complicated, complex disorder, and it's good to know how it differs from other dementias, because there are some very distinct differences, especially in the earlier stages of FTD. So we're going to paint a clearer picture of that. Then we're going to go into the specific FTD subtypes. So with FTD, there are actually a number of disorders that are part of the family of FTD, and initially they start off with usually different symptoms. And I'll just make a caveat here. So I've heard this a lot with Alzheimer's. It's certainly true with FTD. You know, once you've met one person with FTD, you've just met that single individual. And we are going to be talking in generalities, but there are a number of symptoms and changes that can be part of the disease process. Not every individual is going to develop all those symptoms. Not every individual develops them in the same order. So just want to make that clear, because when we go over all these symptoms, it's not like any one person usually has all of them. And then finally, we're going to close with the supports and services that the AFTD provides. We have determined we're going to take questions at particular points during the program. So I think after the first 20 minutes, we'll be taking questions. So this is a good short-term memory test. Hold on to your questions until we take those breaks, and then we will cover whatever you ask. So I am going to turn the program over to my co-presenter, Jen, who's going to turn on her microphone.
We'll get one of these going. Okay. Hello, hello.
Oh, well, there we go. Thank you. All right, can you hear me? Yes. Excellent. All right, let's go over here. Fun fact, today is my first presentation to folks in this type of forum, so I'm very excited. Typically I have worked with lots of folks one-on-one, And so if you hear my voice shaking a little bit, it's because I'm a little bit nervous. But I used to be a teacher, so hopefully that'll work.
No, so here, you take this one,
Thank
and
you.
we'll figure out that.
Okay, how's that? There we go. So this is my mom, Cindy, and my daughters. And my mom, Cindy, is the person who had FTD. She was an amazing person. She was just full of vitality and energy and was just an amazing mom, an amazing friend. And somewhere around 2006, we started to see something was off. And by the time we got to about 2009, we realized that something was very off. And so for the next, just about 6 years, it took us to be able to get a diagnosis of her having FTD. I just recently celebrated her life on September 26th. She died 5 years ago. But that's why I do what I do and why I'm here with you today, because I feel that my story that I'm sharing with you right now is one that shows hope, because I'm not alone and you're not alone. And the people that you see and that you work with have amazing resources, as you'll hear much more about, with each other, with different types of community, with AFTD. So, what is dementia? I'm going to give you all just to take a quick look here. You may feel like you already know the answer to this question, what is dementia? Some think of dementia as a memory problem or as a disease that primarily affects older adults. This is not true, though, of all diseases that cause dementia. Many people can present with dementia in their 40s or 50s, and even as young as 21. My mom first started showing her characteristics when she was in her 40s, and I actually know two people I'm very close with whose children, who were in their 20s, started showing the FTD symptoms. Now, dementia can be present without memory loss as a symptom. The National Institutes of Health defines dementia as the loss of cognitive functioning, thinking, remembering, and reasoning, and behavioral abilities to such an extent that it interferes with a person's daily life and activities. So here's the dementia umbrella. Now, dementia can be thought of as an umbrella term, which means that it can be caused by a number of diseases and conditions. And there are numerous causes for dementia. Some of the most common are Alzheimer's disease, Lewy body dementia, frontotemporal degeneration, FTD, and vascular dementia. Now, the term mixed dementia is used when a person has impairment caused by more than one type of these diseases. The signs, symptoms, causes, ages of onset, and prognosis differ based on the specific disease. How the disease progresses is also different. Oh, yes. Okay, so I know everyone here has heard of Alzheimer's disease. It is the most well-known cause of dementia, and we don't have perfect data on the prevalence of each type, but it is estimated that Alzheimer's makes up about 60 to 80% of all cases of dementia, with nearly 6 million people in the United States currently affected. If you look across vascular dementia, it is also very common, and it can often occur along with Alzheimer's disease. But it is typically caused by damage from a stroke or some other vascular complication. Then we have Lewy body dementia. That makes up about 20% of all cases of dementia. This typically presents with problem solving, motor symptoms, and hallucinations. Then we come down to frontotemporal degeneration. This is less common than vascular dementia and Lewy body dementia, and there are estimated to be about 60,000 cases in the United States. However, FTD is often initially misdiagnosed. This form of dementia tends to have much earlier onset of symptoms, like we said, often when people are in their 40s or 50s. And we think that about half of all cases of dementia may actually involve more than one cause.
So we're going to go into FTD more specifically now. And when I conclude that, then we'll open up for some questions. I'm curious, those of you here today, how many of you, not in your work life, if you're a care professional, but how many in your community life, your family life, your friends, how many of you know someone with a dementia or had someone who's had a type of dementia in your family? Raise your hand. So a lot of us, yeah. So I've had Alzheimer's on both sides of my family. I've also had vascular dementia on at least one side of my family. So, and I think the Alzheimer's Association says that those 65 and older, so that whole big group of all of us who are 65 and older, about 1 out of 10 people, and I believe they say have Alzheimer's living today. And then at 85 and older, it's 1 out of 3 people. So it's not surprising that we all have had some contact with somebody with dementia, but we may not have had, except for those of us that work in care settings, have had contact with a person with FTD. So we're going to talk a little bit more about that. And this first slide, so I'm not a researcher, I'm not a scientist. I have a master's in gerontology, but I'm not a medical clinician, so I have a very basic understanding of this slide, and that's all I'm going to give you today. So it essentially gives you pictures of brain scans of different disorders, and if you look at each brain, the top of the brain would be the front, and the bottom of the brain would be the back, and I believe the scan was taken from the top of the head down. And if you look at the upper left, and I'm sorry, sometimes I'm stepping in the way here. If you look at the upper left, that would be a scan of a normal brain without any particular neurodegenerative condition. Then vascular dementia, Lewy body dementia going down to the lower left, Alzheimer's disease, FTD. And then the condition on the lower right is something called multiple system atrophy. And that's another neurodegenerative condition which primarily impacts movement. So, but if we look specifically at the one in the red box with FTD, you can see that there's much more global deterioration in this area, which would be the frontal and temporal area of the brains. Not to say that some of that isn't happening in other disorders, but you can see it's much larger, right? So with neurodegenerative conditions, my basic understanding is that, these conditions typically start in a very localized spot, which is how the early symptoms are manifest. Often with Alzheimer's disease, I think they talk about the hippocampus, which is the storage cabinet of the brain. With frontotemporal degeneration or frontotemporal dementia, the disorder typically starts in those two parts of the brain. Vascular dementia is a different story in that it starts because of some kind of vascular event or a vascular blockage, like a stroke, a mini stroke, or something like that. And I'm sorry, the other thing about this slide is the red and yellow colors are the most still active or energized parts of the brain. The green parts of the slides are more moderate, and the blue parts are the least active. So you can see that, again, this part of the brain, there's space, but there's also very little activity going on. Next slide. So, interesting. I don't know how many history buffs we have, because this was surprising to me. So actually that is Dr. Arnold Pick, who was in Austria-Hungary, I think he was a psychiatrist, and way back in 1892, he described a person whose symptoms were actually, I believe it was primary progressive aphasia, a patient who had the communication challenges of a person that now we would say has primary progressive aphasia. And then in 1911, another interesting character comes into the picture, which is Dr. Alois Alzheimer's. He worked around the same time, but in Germany, and he was able to look at and see the pathology, which ultimately was called Pick bodies, named after Arnold Pick, which is one of the brain anomalies that are part of the FTD spectrum. So not all people that have FTD have Pick bodies, but it's become associated with FTD, and the name Picks is still sometimes used in a broader way, and I would say not clinically appropriately, because Picks is really a particular type of FTD, but we won't stay on that. And then it really wasn't until the 1990s when we started to learn more about FTD. In terms of 1993, the establishment of some clinical criteria for medical conditions, medical practitioners, such as doctors and neuropsychologists, to basically determine whether someone has possible or probable BVFTD, and then more research in the 2000s in terms of, my microphone seems to be going in and out. I don't know if it's how I'm holding it or,
well, we got talking to it, so we'll just keep on.
Give them a rest. Don't we all want to rest every now and then? So, is this working now? No. All right, we'll try this one. Hello, that one works. Okay. I talk pretty loud, but anyway, this helps. So the other thing that's been discovered, so if you know Alzheimer's, you've heard of amyloid plaques and tau tangles, right? So with FTD, there are also misfolded proteins like amyloid and tau that come into play. And then also with FTD, unfortunately, there are some genetic relationships related to FTD, and I'll go into those more specifically later in the program. But you can see there's been a lot of research and development more recently. Certainly not as long has been in place with Alzheimer's disease. Next slide. Okay, so I think the most basic thing that I want to get across is FTD is not a single disease, but it's a family, a spectrum of disorders that are related either because of the type of misfolded protein that occurs and where the deterioration first starts. There's some dispute, but I'll say it is one of the leading causes of dementia younger than age 60. So generally, it's called a younger onset dementia. With Alzheimer's disease, there are certainly people 65 and younger that develop the disease. I think about 200,000 nationally, so a bigger group of people than the 60,000 that we mentioned with FTD, but it's a smaller portion of the total number of people with Alzheimer's, whereas in FTD, the midlife development is a larger portion of the overall patient population. The symptoms that initially are the hallmarks in terms of changes typically start with changes in personality or behavior, communication, speech or comprehension of language, and or movement. And I will go into the disorders specifically, so I'll give you more information than that. Jen mentioned that unfortunately it takes a very long time for families to get a diagnosis. Imagine if you or a loved one were experiencing these marked changes in function, and it took 3.6 years on average to get a diagnosis. Part of that is because the wide array of symptoms, that FTD is not as well known as we certainly would like within the primary care world, and also to give the primary care world some benefit, it's less likely they're going to see a large number of patients, so it's unique to them. But we are working at trying to find a better doorway to diagnosis. So that's part of what we're doing. Because of the time to diagnosis and the early onset, there's a different family burden. So often people are still working. The person with FTD symptoms may be the primary wage earner. The family health insurance may be associated with that person's job. If there's a family, they may be paying off a mortgage. They may be sending college-age kids to a university, trying to save for retirement. And all of those things get thrown into chaos with these drastic symptoms and changes that happen. Next slide. Okay, so this is a drawing of the brain, and primarily it's just to give you a perspective of where the frontal lobes are and the temporal lobes, and what basic symptoms or functions are covered by those parts of the brain. And you can see in the frontal lobe, it has a lot to do with behavior, personality, reasoning, planning, problem solving, inhibition and initiation of action. There is some element of physical movement that also takes place there, but that has a lot to do with people that start with BVFTD and behavioral variant FTD. The temporal lobes, on the other hand, are more communication-based in terms of speech production, recognizing visual pictures or pulling words out of your brain when you see a picture, and understanding language. The other part of the brain that's kind of hidden away here that comes into play in particular with the movement disorders is the basal ganglia and then the brain stem. So the basal ganglia is deeper in the brain, and it's kind of, I would say, behind the temporal lobe, and in an area where, as neurodegeneration continues, and it does, because FTD is a disorder for which there is currently no FDA-approved disease-altering treatment. So it is a terminal illness. We say on average, 7 to 15 years. It all depends on when a person is diagnosed, what part of the disease process, but there is no treatment that stops, slows, or reverses the disorder. Next slide. Okay, so I'm going to just quickly go over this one because I'm going to talk more in detail about each of these, but essentially to give you an idea of what are the 3 types of functional areas that are impacted. But before I do that, let's just jump up to the top. So there are a lot of things about FTD that are confusing and can be confusing. We're trying to figure out how to make it less so, but one is the name. So some people use the term frontotemporal dementia. My organization uses frontotemporal degeneration. Some clinicians and researchers use frontotemporal lobar degeneration, and then at times people use Pick's disease. So I'm not going to go through the whys and wherefores. The easiest thing is if we just use FTD, we're talking about the same thing, okay? So on the left-hand side, about 50% of people who have FTD start with behavioral and personality symptoms and are diagnosed with behavioral variant FTD, acronym BVFTD. Then the next more common conditions are primary progressive aphasia, and that disorder is one which impacts communication. And there are some subtypes of that I'll go into very briefly shortly. And then on the right-hand side, you will see that there are progressive motor function or movement disorders that are part of the FTD spectrum. Corticobasal syndrome, CBS acronym, progressive supranuclear palsy, which is PSP. And then finally, there's some individuals develop both FTD and ALS. And so they have both of those conditions, not necessarily right from the get-go, but starting with one and then develop the other condition. And there's often a genetic component to that I'll talk a little bit about. Next slide. Okay, so I'm going to talk about BVFTD. So, I think having worked in a skilled nursing facility and an adult day setting, behavioral challenges, people that have changes in personality or behaviors are often, from my perspective, can be challenging in terms of working one-to-one or working in a care setting where you have multiple residents, patients, participants. These are common symptoms, and these 6 symptoms are part of the symptoms that a neuropsychologist or a neurologist are going to use to diagnose whether a person has probable or possible BVFTD, along with a brain scan. But apathy. So apathy, as a general term, lack of interest, lack of motivation, unwillingness to get up and go and get up and do, not uncommon with a lot of conditions. Certainly, apathy can be a symptom that's part of depression. And that is one of the things that gets people with BVFTD referred not to a neurospecialist, but to a psychiatrist or a psychologist without neurology specialty, and then they get a diagnosis of depression. What tends to be distinct and different about apathy with people with BVFTD, like a red flag should go off, that the apathy does not have an accompanying sadness or sorrow or grief. So with grief and loss, older adults sometimes develop depression and they can be apathetic, but usually a good clinician can tease out there's something that happened that they're sad about. That doesn't tend to be part of the apathy. Disinhibition, so doing and saying things that are socially inappropriate, right? The mechanism that's part of the frontal lobe that controls and monitors and manages, you don't say that thought bubble that's in your head, that goes awry. I'm going to hold off on executive skills, loss of empathy. So, many of us are in like a social service caring field. Empathy is an important characteristic to have, and certainly in our own lives, we want for our partners to have empathy and be able to feel empathy. With BVFTD, an example might be, a father who's always been very loving with his daughter, the daughter who is the apple of his eye. She has gone off to college, started her career. She comes home to visit mom and dad, and she announces and is really excited because she's been asked to marry a young man that she's been seeing for a while. She's very, very happy, very, very excited. Mom is jumping up and down. Isn't this wonderful? Can't wait to start planning the wedding. Dad is sitting there still watching TV, and he doesn't have any expression of interest, any excitement, And that's the kind of thing people notice. It's something, what's wrong here? You know, Dad was always someone who really was interested and paid attention, and now has no excitement or interest in someone else's perspective. Changes in eating habits or diets. So I would say people that never had a history of, you know, always eating candy, you know, constantly eating candy, or drinking alcohol, or being very specific in their dietary habits, that can be a symptom. Compulsions, you know, ritualistic behaviors that, again, a person never had that in their past personality makeup, they start to come into play. And then finally, a deficit in executive functioning skills. So I think of that as a person's ability to, like, manage a multitask sort of activity, to plan, to problem solve, to kind of take care of something that's more than just a one-step process, and that can be impacted. So all of these areas, unfortunately, these symptoms are not commonly addressed if someone just does like a mini mental status. You know, it's not memory. It's a more comprehensive assessment that has to tease out something like this. Next slide. Okay, primary progressive aphasia, another disorder with FTD. And on the left-hand side, non-fluent agrammatic. It's primarily, at least initially, a challenge with speaking and communicating. Often people with non-fluent agrammatic PPA really struggle to get words out. I mean, in videos of people with that type of PPA, it's almost painful in terms of expressing the language. Semantic PPA is more about comprehension. So presented with a picture of a truck, they're not able to label that word or other words that are common. They can't pull a simple, commonly known word out of their head that's related to a picture. But their speaking is typically not as impaired in terms of how they phrase and what they say. And logopenic, finally, is a difficulty with finding specific words, but not in getting the words out, but finding a particular word that they're trying to communicate with. Logopenic is often driven by Alzheimer's disease progression, but not always. Next slide. And I think I've overdone our 20 minutes and then questions, so I have only 2 more slides and then we'll take questions. So the FTD movement disorders, cortical basal syndrome, I'm just going to quickly go over some of the more dramatic differences. These two are sometimes called atypical Parkinsonism, and often initially they're diagnosed as Parkinson's, and it's upon further presentation of symptoms or the fact that Parkinson's medications may not be effective with these diseases that it becomes more apparent that they have an FTD disorder. So with CBS, it often starts on just one side of the body in terms of the impairment, so asymmetric Parkinsonism. There can be the phenomenon where an arm or a limb just gets lifted, you know, without an intended reason to do that. And certainly getting balance is a problem. Progressive supranuclear palsy, one of the symptoms that's common is the inability to raise and lower your eyes. And it's very marked in terms of a movement specialist assessing somebody. They just, for some reason, cannot raise and lower their eyes. Sometimes it's left to right, but more often it's up and down. The other thing is a blank or surprised stare. So you see they constantly have a facial expression like they're surprised about something. So that would be another hallmark. As well, with these disorders, it's not uncommon that they also start to exhibit some of the other FTD symptoms. We'll move on to FTD ALS. And so I'm not an expert in ALS, but in my mind, as a generalist, I think of it primarily as a movement disorder where over time the body continues to fail in terms of the ability to move and to act, but that generally the cognition remains fairly good until late in the disease, whereas a person that has FTD ALS, they're going to have symptoms from both of the disorders, and this in fact is the genetic mutation which is sometimes at the core of people developing this disorder. And I'm going to talk a little bit more about genetics on another slide, but I won't go into that right now. And I think we're going to pause and see if you remembered that question that you had about 20 minutes ago. Any questions about any of the disorders? Anything you want to ask? Yes, sir.
How do they diagnose all these things? And who does it?
How do they
diagnose? How to get definitions?
So the gentleman asked, how does someone diagnose these disorders? Well, it's a long process in terms of people finally getting to the right clinician, but in general, a person is going to get a diagnosis by, first of all, there are a number of FTD centers around the US, and if people are experiencing these symptoms or their family members are noticing them, one possibility is to call our helpline, because we have those FTD diagnostic centers on our website and we can share that information.
And I would say too, from my mother's experience, one of the things that happened, thank you,
was a process of elimination. So we went through, she actually showed signs across all of the things that you heard Will talk about. And so what happened was, I was working with the doctors and we literally just started going through and saying like, okay, it could be this, but it doesn't really meet the criteria for that. So from what I've heard from other people I've spoken with, many times it can be something like a process of elimination where you try to say, oh, it's really not this, it's really not that, but it's a conversation that you have with your doctors to kind of get to that point.
Right, but it is a clinical diagnosis, so there's no blood-based biomarker currently that you could go out and have to test for FTD. So in the best of all possible worlds, a person with the symptoms gets referred to a neurologist or a neuropsychologist or a neuropsychiatrist, someone who has a neurology specialty. And the kicker and the challenge is initially the symptoms can look like something else, and if a person gets referred to a psychiatrist who's not a neuropsychiatrist, they're going to potentially diagnose them with a behavioral health condition and treatment will ensue. So it's about getting through the right doorway, and part of our work on the helpline is to help families figure that out. I mean, certainly one of the FTD centers in this greater area would be at Johns Hopkins, and there certainly may be other dementia centers in the area. There is one on our website, and I'm not remembering the name, but if it comes back to me, I will bring it up. The University of Virginia in Charlottesville. So actually, I think Johns Hopkins is closer, but those are the two sites that we have listed.
The question is, the patient does not admit it, doesn't want to go. How do you get the person to do it?
Wow, if I had the answer to that question, I would write a book and I would make millions of dollars. Oh, the question was, the person doesn't want to go, they don't recognize they have the disease. So that is one of the symptoms that I didn't mention, but I'll mention it now. So there's something called anosognosia, which is a lack of insight, and that can certainly be true of people with Alzheimer's disease, but it does come into play with people with FTD as well. So it's really a difficult dance of, we often problem solve with people over the phone, like, well, what have you done? How have you proceeded? Certainly there's this whole thing about HIPAA and doctors not wanting to talk to care partners, but part of trying to get around that is sometimes those clinicians are open to listening, they're just not going to share information with the caregiver. So I know in my situation, so my dad has dementia, probably Alzheimer's type, part of it is sharing information with the clinician that frightens them enough that they want to do a diagnosis, right? So, but there are challenges to that, and thank you for acknowledging that. We'll take one or two more questions, and then we probably have to get back.
I would just like to know how you go about getting the correct 1-800 number for, because I have a brother that's going through this, and he's probably going to be the same way he's saying he's resistant. So I want to just find out how you get the correct 800 number.
Sure, and believe me, I don't have that number memorized, but it's on all of our information. Maybe Jen has it memorized.
It's all over
yeah.
here at this table.
So, and it's also on the front of the slides and the end of the slides. Please pick up information. So we have a helpline that takes calls and talks to people directly, and we also have an e-helpline where we can get contacts from people to get information, and I just don't shoot that number out of my head very often. One last question, then we should move on.
Okay, do you have another one? Okay, thank you.
It seems what we know here, dementia and Alzheimer's, in terms of early on, how to look forward. So when we bring a child into the world, we know that we've got a hereditary problem with dementia. It doesn't seem like there's anything early on that we can do to sort of not ward it off, but to make it possible so it's not going to be a death sentence.
Well, so the comment, yeah, so the comment was sort of on why don't we look at this as a more lifelong kind of thing in terms of dementia. And certainly there's plenty of research to acknowledge, and I'm thinking more in the general dementia research and more in the Alzheimer's research that, there are a lot of things about childhood and, education, even early education on through grade school, and lifestyle traumas that can come into play. It's just that, well, I would say societally, we have to have an interest and then determine that it's something we want to look at and fund. But the thing that I will mention, I'll get it back to FTD, is that when we talk about genetics, the other thing you should realize about FTD, we already know there's a stronger genetic component to FTD than Alzheimer's. So that is the area, and what I mean by that, the number of people that develop FTD, though it's overall small in terms compared to Alzheimer's, roughly 60,000 or more, the genetic relationship is 10 to 20%. So it's a higher percentage in terms of genetic relationships. So we're going to move on because we are 10 minutes to 1, and we've got a lot to talk about.
Hi, folks. All right, so I'm here to talk to you about my lived experience with a lot of these pieces too. So as I'm talking with you about what you see up here, a lot of these are things that I lived through with my mother's disease. So a few years ago, AFT did a study on the cost of FTD with responses from nearly 700 caregivers and care partners. And I actually was one of those people who responded to that. The study concluded that the average annual costs associated with FTD are roughly double the costs that are associated with Alzheimer's. And I'm just going to let that sink in for a second. We're going to be talking about a lot of money pieces here, but this is a huge financial change, a burden. It affects people in the long term. They also found that 12 months prior to diagnosis, overall household income ranged from about $75,000 to about $99,000, but 12 months after diagnosis, the income declined to about the $50,000 to the $59,000 range. And again, as Will talked about, the impacts that this has on a family, particularly if these are folks who have kids who are in school, and this might be the primary breadwinner. You're talking about, every single aspect of your life is being affected by this, but then also you have the burden of trying to get to see all the doctors and see all the specialists that you need to see. So it can be devastating. 1 in 3 caregivers, as a matter of fact, stops working after a loved one's FTD diagnosis. And I was one of those people because there were several things that were happening at the same time, and I could not go to my job. So I had to leave because I was a teacher. I needed to be in the classroom. So, it's a real thing that happens as, you're talking to folks and experiencing, what people are going through with this. So let's take a look here at, now also, we can talk about significant role changes in a family. So there might be, as we've said, children, teens, or young adults at home, and or perhaps the person's care partner is also caring for an aging parent or someone else that needs their assistance. So you then find a situation where the people who are in a household really have to change kind of how things happen, and that's where you also might see things like kids might have to drop out of college, or maybe things are affecting their schoolwork, because their role within the family is now completely different. So to summarize, basically FTD diagnoses really create complex and difficult financial and social changes within families. All right, so kids and teens. Unlike many other dementias, FTD, as we've been saying, usually occurs and hits people in about middle age. And so you will much more often than with, let's say, other types of dementia, particularly with Alzheimer's, you will have kids and teens who are at home, and the caregivers and the care partners are the folks who are trying to find a way to meet the needs of these kids, as well as meeting the needs of their partner. But there was a question over here, gentleman, before I didn't see him, but kind of talking about looking at anticipating needs, and what can we do to help folks through this. Well, one of the things I found that was interesting is that children, particularly teens, I taught high school, they don't want to talk about this, so it can be hard sometimes to reach out, because this is something it's embarrassing, and it has probably caused a lot of upheaval in their lives. So one of the things that we're trying to do, and you will see also in our resources, we have things like this. What about the kids? And there are care group or support groups for kids and teens and young adults. And those kinds of things we think are helping the kids who have experienced this huge upheaval to get through this devastating period in their life. Okay, so sorry, I'm just double checking. Okay, so helping families build a care team. We've already heard before that it is important that you have numerous places, and the person who has FTD has numerous places that are supporting this individual and their family. We will start with family, friends, and community, which might seem super obvious, but I think one of the things that I have discovered talking to folks is that many people have to change their definition of family, or change their definition of friends and or community, because a lot of times you will find support in places you weren't necessarily expecting it. I found a lot of support when I started reaching out to the folks at AFTD. I started meeting people, talking to folks online, talking to people over the phone, and that became a huge piece of support in my life. You need your medical team. Clearly, you've got your primary care doctor, neurologist, nursing staff, etc. We've got social work, and under there we're talking about therapists, and you might also need a speech and occupational therapist within there. Another piece we haven't touched on yet is elder law. So there are a lot of complicated legal pieces that might come along with this. That is a piece that the family will need to look at as far as advanced directives, as far as looking at who has power of attorney and healthcare power of attorney. And then when it is time, we're looking also at palliative care and hospice towards the end of the person's life. But basically, what we're just saying here is that there's a very large web of people and groups that can help support the person and the family who have FTD, and it's important to make sure that we look kind of outside of just your family and your immediate doctor that you're working with. All right, support groups. Support groups are so much better now than when I first was working with folks, because I didn't have really, there weren't that many web-based groups, but what I have seen now, there are many resources that you can go to for support, whether it's in-person or web-based. A thing I would like to draw your attention to is you're going to continue to see this website, www.theaftd.org. When you go there, and I would very much encourage you, if you have a little bit of time now, at the end of this presentation, maybe pull it up on your phone and take a quick look. But you will find that you can go under, there is a support tab, and we actually have every state, and you can go to those tabs and you can find support groups, you can find folks who are on there, like I'm on there from Maryland. You will also see some other, I know Will was talking about some of the hospitals or medical groups that you can reach out to. So that is another area in which we're trying to provide information to folks and give them a source to find the support that I'm sure they very, very much need.
And it just so happens I went to look this morning, and there is a Fairfax group listed on our website, as well as one in Richmond and Hampton. So
The Fairfax group is with Insight Memory Care.
there we go. Thank you very much. And Jen, I will just mention, between the two of us, we need to fast pace it, because we're almost at 1 o'clock, and I think some of these folks are going to start getting up and leaving us if we don't end close to the time. So why don't you go over that slide, and then we will go through quickly and make sure people get a little bit of something.
There we go. I think I lost it again. Thank you.
Okay, just very quickly, we've already talked about this, the time to diagnosis. From the time that my mom first started showing some signs in about 2006, she wasn't diagnosed until 2014. And by that time, we actually weren't really able to do a bunch of tests. So early diagnosis is extremely important. Okay, what to do if you see warning signs? So everyone can see one here that you will be doing sort of, not the standard things, but things that you would do for any other type of disease. You would have your health history. When you see that there is something going on neurologically, you should have a neurologic exam. One thing I would like to point out is that people ask me frequently what to do if there are warning signs, and we've talked about this, but it's really important to keep in mind that when we're talking about some of these warning signs, this is not, oh, I started to kind of forget a couple words, or, oh, this person's acting maybe a little bit differently. It's usually very intense, very repeated, and progressively worse behaviors that will get you to this point. So let me see, we've got brain imaging and neuropsychological testing, speech evaluation. I don't know, see if there's, am I missing anything here with?
I think this is a pretty, even with Alzheimer's disease, I think these are pretty common aspects of getting a broad, comprehensive diagnosis for a dementia, although in some instances, obviously, a speech evaluation might be involved if the person has primary aggressive aphasia, but not one of the other disorders. So, you know what, let's go on to the AFTD slide, and I'm going to say a few things about treatment and research. You have the slides. either in your hand or a PDF. So the good news is that there's a lot more research going on right now with FTD. There are at least 12 studies across the country. Obviously, it depends where the person resides. There are definitely FTD treatment studies, as well as symptomatic studies, as well as caregiver studies. My organization, AFTD, is a place to go to find that information. There's also another sister nonprofit called the FTD Research Registry. It's in your slide. You can also find it on our website. And I feel like we're doing a little microphone dance. And so the thing that I mentioned earlier, there's no disease-altering treatments. Physicians do prescribe other medications for some of the symptoms, and they can be effective, but it's a sort of a trial and error approach. And then also, clearly there are therapies like speech or physical or occupational therapy that can help. If you can forward on to the genetic slide. Okay. So just to be clear, with FTD, there are a number of genes that have been found to be causative, autosomal dominant genes with FTD. And what that means is we each inherit 2 genes from our parents, and with an autosomal dominant gene, if one of them has that gene, we have a 50% chance of inheriting it from them. And so unfortunately, in families with FTD, since there's a higher genetic role that's played with the disease, it can mean that multiple family members develop an FTD disorder. Tragic for families, very difficult. It is an avenue for greater research, and some of the treatment studies are related to specific genetic variants. We'll move on. Let's just go to the AFTD slide, the resources. And next slide. Okay, so this slide gives you a sort of quick snapshot of how we help families. I want to just mention a few of these things. So we do have respite grants for families, up to $500 for respite or for quality of life for the person with FTD. Not everyone knows about that. We give them out every year, and it's not income specific. We also, as mentioned, we have support groups, we offer education, and we have a helpline, and there's that helpline number, 1-866-507-7222. And finally, the last thing I'll close for most of you healthcare professionals. So we are really engaging to educate and inform healthcare professionals. So this Thursday at 3 to 4 p.m. Eastern Time, we have an educational webinar that offers continuing credit for doctors, nurses, social workers, and you can get a certificate with other healthcare professions. It's free. It's about FTD genetics, and then a UCSF researcher, Dr. Yubenkov, will talk about genetic research. We have been offering continuing credit webinars since last June. And so the best way you could find out about those is to sign up for a professional mail list. The other thing that we sent that around, the other thing I want to mention is I'm part of a group at AFTD that puts out a quarterly healthcare professional newsletter called Partners in Care. It's free. One of our recent issues was finding the way successfully transitioning to residential care. So it was all about how those of us that work in community care settings can better understand and provide person-centered care for those with FTD. There's a behavior chart with examples and then strategies and approaches. We really want to help you help families living with FTD. So I just want to acknowledge, for those of you that are in the senior field and especially caring for somebody with dementia, you really have to have a strong commitment and passion and have a great way to de-stress. Mine personally is a glass of wine at the end of the week, But whatever you do, it can be very challenging, certainly for family caregivers, but also for professional caregivers. And I wish for you some joy and peace and love for the holiday season, because you obviously are giving that to your the persons that you care for. So we are going to stop here and see if anybody still wants to ask a question before you run off to the next part of your life.
Okay, looks like we got a question over there.
Yes.
Partners in Care, how do I sign up to get that publication as well as sign up for the webinar?
Okay, so we had a sign-up sheet for Partners in Care. Did we run out of them? They were at the registration table.
There are some going around. There's one right there.
There we go, and she has one. And to sign up for the webinar, let me get you a flyer. You need to go to the website, okay?
All right. Well, yep, got a question here.
Yeah, just real quick. This is just with diagnosis. Why is it that there's so many questions? Why can't, you showed us the brain scans. Why isn't that something that's a little bit more definitive for us to get that diagnosis in the beginning?
Because getting a brain scan in and of itself, like getting on the road to getting a scan, those are PET scans, and I would say PET scans are expensive. You have to get to the right person who will make the referral for the PET scan in order. And the other thing is PET scans don't show early deterioration. So a person, those slides were like really definitive in terms of deterioration, but there are people that have FTD who could have a scan, and unless their frontal or temporal lobes are markedly different, the person looking at that scan might not even notice that it's slightly smaller, That's the answer to that question.
All right. Well, given that everybody's getting up, what I'm going to say is this is the fun part. Number one, let's give Jen and Will a big round of applause. Number two, feel free to hang out, and especially those that may have questions or loved ones that are faced with any kind of caregiving issue. There's lots of senior living providers here. Introduce yourself to anyone and everyone. This is a very welcoming community, and Will and Jen will hang out and can answer your personal questions. And then I've got everybody's email. We'll send you the PowerPoint so that you can reference all those things, as well as some other valuable links. So have a great day, y'all, and we'll see you at the next one.